morning, good afternoon, good evening, and welcome to our third webinar in the IPOL policy series. Tonight, this morning, we're privileged to have David Sanders from PHM in South Africa speaking with us about health systems and primary health care. Good morning, David.
Hi, afternoon for me.
Oh, good, okay. Now, it's going to take a few minutes for everybody to join the webinar, so perhaps we could start by introducing you. I guess I know that you're a senior person within the PHM. What brought you to health activism in the first place?
Well, it's a long story, excuse me, but I suppose it really was when I was a medical student training in Zimbabwe in the 1960s, long time ago, and I well remember in the pediatric wards treating children who were very ill from complications of measles and malnutrition, and being very well aware that both malnutrition and measles could have been prevented by vaccination, but also through improving food security and reducing poverty. And I saw many children like this, and many of them died unnecessarily. So I think that alerted me to the issues of social determinants and social justice. And at the same time, the national liberation movement in Zimbabwe was beginning. So I think there was a confluence of both my medical experience as a student and my awakening to what you might call the politics of health with the broader political struggle that was going on.
I guess you're not the only person who's been brought into health politics in the context of that kind of political struggle. I think it's probably quite a few people in Latin America as well who follow the same pathway, huh?
Yes, I think that's the case also for people like Maria Zuniga, who was, I think, on this a couple of weeks ago.
Yeah, okay. So let's get started, David. Thank you very much for being available, and perhaps you could share with us your insights into health systems and primary health care.
Yes. Do you have any idea, David, of how many people are online at the moment?
They're gradually coming online. There's, I think, about half a dozen at this stage, and more coming.
Okay. So should I start immediately, or do you want me to delay by a few minutes?
I think if you start now.
Okay. All right. Well, whoever's there, I can't see you. Very nice to be performing on this medium. Our father prefer performing face-to-face with people, because then you can interact with them and see whether they're asleep and so on. So I'm going to talk today about health systems and primary health care. And you can see the title. I'm looking very briefly at the history and then at the evolution of primary health care and of health policies, with primary health care at the center of them, and the revitalization of these, some of the challenges and opportunities which exist. So I'm going to look at the rationale for PHC and later for health sector reform and some of the continuities between the two. Then look at health systems and some of their chief components, and finally end up with key actions and strategies with some illustrative examples. Clearly, this is a very big topic, and I can't possibly cover it in any depth in this short period. So, primary health care, which, as you probably know, was codified in 1978, was preceded by a number of very important initiatives. One was an initiative in East Africa in the 1960s, out of which came a book called Medical Care in Developing Countries, and another one published by WHO. And both of these focused really on building up the peripheral part of the health system, because health systems had been very hospital-centered. So there's a focus really on health centers and on staffing those with what were called, at that time, auxiliaries, and which we now term mid-level workers. Another important stream which fed into the primary health care initiative was work which was done, epidemiological work, historical epidemiological work, done by especially McEwen, who worked in the UK, who demonstrated the importance in health improvement of what we now call social determinants. And many of you, I hope, will be familiar with this very important graph, which shows in the UK, since the time statistics were first kept in 1838, a marked decline in deaths from tuberculosis long before any effective chemotherapy, streptomycin in that case, and vaccination were available. As you can see, that these were only discovered in the 1940s, and yet TB mortality had declined very significantly before then. So clearly, this was due to non-medical factors. And these non-medical factors were environmental, and key in the case of TB were, of course, better housing, better ventilation, better working conditions, and, of course, better nutrition, which improved people's resistance. But this didn't just come about as a result of enlightened reformers. And there were many reformers, like Chadwick, Shaftesbury, and many others whom you may have studied in social medicine or public health. There was a significant social mobilization, popular struggle surrounding some of these reforms. On screen now is a poster from 1832 in London, where people are protesting about cholera in London and noting that it comes from really an infected environment. The main thoroughfares are still without common sewers, and unless something is done, the growing discontent of the people will be felt. Signed by Salus Populi, which means health for the people, or health of the people. So, much closer to Alma Ata in 1978, there's a book published by Ken Newell, Health by the People. He was working for WHO at the time, and this describes several community-based projects, the role of community health workers, at that time called village health workers, and a number of large-scale programs, notably in China, where a more comprehensive and basic approach to healthcare had been employed and had resulted in very, very impressive advances. So these went into thinking and planning for the Alma Ata conference. So here's a picture of where the Alma Ata conference took place. This is actually the conference. I wasn't there, but as you can see, mainly men in suits and a lot of them smoking. Times have changed a little. So this is the hall where the famous conference where Health for All was declared as the goal for 2000 happened. So what is primary health care? So I think many of you will know that primary health care has a number of principles which emphasize equity of access and coverage. So, in other words, access and coverage based on need. Comprehensive care, I'll come to that later, with an emphasis on prevention and promotion. And community and individual involvement. Then also intersectoral action to address social determinants, and also an insistence on appropriate technology and cost effectiveness. And these principles were to run through the programs of primary health care, or the elements. And they are listed here. You can see they're about improved socioeconomic and environmental conditions like nutrition, sanitation, and so on, a strong focus on maternal and child care, on infectious disease, on health education, and on treatment. So what's missing from this clearly are non-communicable diseases. And non-communicable diseases, of course, are becoming much more important, but at that time were not recognized to be very significant in especially poor countries. So the concept of primary health care was explicitly political in that it not only stressed a more equitable, appropriate, and effective approach, which we call the basic healthcare approach, but also had strategies to address the underlying social determinants. And this is a quote from the Alma Ata Declaration, which was quite prophetic, noting that there would be great resistance to primary health care because essentially of its community development potential, which might threaten powerful interests. So primary health care addresses the main health problems in the community, providing, as this quote from Alma Ata says, promotive, preventive, curative, and rehabilitative services. So the rehabilitative and curative are primarily individually focused, and preventive and promotive are primarily population focused. And promotive interventions really address the determinants by, for example, legislative and advocacy actions and intersectoral actions taken at all levels of the system. So comprehensive primary health care really comprises both individual clinical care and public health intervention. So it's a very broad concept and in many ways very revolutionary. But not long after Alma Ata, there was a split in the primary health care movement, with a focus on cost-effective technologies, which is welcomed, but at the same time, a neglect of what you might call the public health aspects of primary health care. So, for example, UNICEF with WHO launched in the 1980s what they called their Child Survival and Development Revolution. And those of you who are old enough may remember GOBI, which stood for Growth Monitoring, Oral Rehydration Therapy, Breastfeeding, and Immunization. And then, because various other constituencies protested, they added on 3 Fs. So it became GOBI Triple F. So what was the problem with this? Well, the problem is illustrated by just taking one health problem, diarrhea. If we look at all of the possible rehabilitative, curative, preventive, and promotive interventions for diarrhea, you can see that the GOBI approach only supplied some of those actions, and those are in circles on this slide, but completely neglected the promotive interventions, or if you like, the public health interventions addressing environmental and social determinants. So primary health care was launched really very close to the global debt crisis, which occurred really in the 1970s, and followed by structural adjustment policies, where countries really very significantly cut spending on health and other social measures. So this really undermined many countries' abilities to actually implement primary health care, although it was at the core of their health policy, and remains so. So in the 1990s, late 80s, early 90s, health reforms were promoted, and many of you in the countries in which you work will know of health reforms. So these are the components, the key components of health reforms. And I've put in bold some of the ones that are extremely common around the world. But essentially, this was, in many ways, a subset of neoliberal economic policies. You can see that the private sector is very explicitly involved in healthcare provision from about that period. And when they talk about actions to improve the functioning of national ministries, often that entailed cutting posts in ministries of health. But really, there was a very strong focus, and is a very strong focus, in health sector reform on economic efficiency. And cost effectiveness has very much dominated healthcare policy over the past couple of decades. Now, we're all very interested in cost effectiveness. The problem is the way it's been employed has been to calculate the cost effectiveness of mainly single interventions, like, for example, vaccination or vitamin A supplementation or TB treatment, but not of the broader social interventions such as improved food security or improved water and sanitation and so on. So here's an excerpt from the Sachs report of 2001. And if you read it, you'll see that there is a point made that water and sanitation are very costly, and that we should invest rather in educating people to wash their hands and making soap available, because this is a much more easily measurable and very cost-effective intervention, but clearly cannot happen without water and sanitation. And one of the results of this kind of focus, it's not the only reason for neglect of these problems, has been a huge backsliding of water and sanitation provision, particularly in Africa, over the past few decades, with very, very large and increasing numbers of people having poor access to both water and sanitation. So primary health care includes addressing the social determinants. I won't dwell on this cartoon, but this really expresses it very well. And this cartoon comes from a book which David Werner and I wrote, and which you can download for free if you're interested. The website's at the bottom, and you'll be able to pick it up later. So this kind of approach of health reform has been accentuated by the development also of a different funding architecture, privileging of what are called global health partnerships or global public-private initiatives. What are they? So these are entities that mount and fund a selective response to specific problems. Some focus on developing or increasing access to health products, such as drugs or vaccines, and Gavi, the Global Alliance for Vaccines and Immunization, funds this. Others attract, manage, and allocate funding for a global response to specific diseases, such as the Global Fund to roll back AIDS, TB, and malaria. So many of these have been established, especially in the 1990s and 2000s. And now there are well over 100, I believe over 140 different global health partnerships, which of course fragment very significantly the funding field. The good thing is that, especially for HIV and AIDS, the advent of the Global Fund and of PEPFAR, which is US funding for AIDS, AIDS in particular, have greatly increased funding available to counter the HIV/AIDS pandemic. That's the good side. But developing countries, low middle income countries, complain that their agendas are increasingly driven by donors. They spend a lot of time accounting to donors, and there are long delays often in disbursement, and sometimes it's very difficult for governments to implement their own policies. For example, in 2000, Tanzania hosted 1,000 donor visit meetings in that year. And this shows in Kenya how the supplies and logistics system looks like a spaghetti. You can see that the source of funding for commodities in the second row are so numerous. USAID, DFID, UNFPA, the government of Kenya, UNICEF, etc., etc. And this is, of course, the supplies and logistics system is just one component of the health system. And now we are seeing what many of us worried about, the problems of sustainability of some of these crucial programs, like programs to address HIV. Because if you look at this slide, you'll see that in 2005, the great majority of funding for HIV/AIDS, especially antiretroviral therapy, is donor dependent. You can see the very tall pillar is PEPFAR, and then next to it the Global Fund, and the purple one the World Bank, and the tiny little blue bar is government funding for HIV. So of course, if bilaterals and multilaterals start withdrawing, which indeed they have started to do, funding to the Global Fund or for PEPFAR, then you see that the sustainability is threatened. And also, these kinds of funding initiatives have privileged certain areas of the health sector, particularly those focusing on HIV, TB, and malaria, and without an increase in health personnel or human resources for health, often health personnel are shifted away from other parts of the health service. So all of this together, of course, very fundamentally, with countries' indebtedness, failure to invest significantly, most of them, in health sectors, has led to big problems in improvement of health status and of delivery of programs. So here are some recent graphs from UNICEF showing stagnation in coverage of DTP3 immunization, of oral rehydration therapy with continued feeding, of vitamin A, of pneumonia care-seeking behavior. You can see that the coverage of these key and not very complicated interventions leaves a lot to be desired. And when we do an equity analysis, looking at coverage by the lowest and the richest economic quintile, respectively light blue and dark blue, you can see for the light blue bars, the poorest people, coverage of key maternal and child health services is really very, very poor. So the World Health Report in 2008, which focused on primary health care in the 30th anniversary year, talked about some worrying trends, much of which I've been talking about over the last 20 minutes or so. So you can see they worry about health systems that focus too much on narrow, specialized care, where there is a fragmentation of service delivery, and where involvement of the private sector has allowed unregulated commercialization. So what then are health systems? So this is the current WHO definition of health systems. And I've put in bold what health systems are intended to do, namely, to all the activities that promote, restore, or maintain health. So you can see in the list, the bulleted points, there are household and community interventions, facility-based interventions, broader public health interventions, such as anti-smoking campaigns, involving all categories of providers, and various mechanisms to finance the system, as well as the regulation and the professional bodies involved in stewarding the system. So it's a very, very broad definition. But it's kind of been dumbed down, in my view, much more recently by these 6 building blocks, which some of you may be familiar with. Governance, financing, health workforce, health information systems, supply management systems, and health service delivery are the 6 building blocks of the health system. And clearly, there are problems in envisaging this as discrete blocks. So there's been quite a lot written recently about the processes. So in Wikipedia, they make the point that health systems should not be expressed only in terms of their components, but also their interrelationships. They should not only be about the supply side, but also about the population, about the involvement of populations, and in terms of their goals, not only on health improvement, but also equity, responsiveness, respect of dignity, amongst other things. So there is a conversation going on about how we should see health systems and what sort of health systems we should aspire to and try to build. I think I'll leave this one out, but it really is a slide about the different understandings of universal coverage. And it makes the point that universal coverage comprises 3 components, namely broadening the range of programs and making them more accessible, extending them to all citizens, and providing social protection against financial risks. And it's clear that certain agencies favor really just the last part, namely protection against financial risks, and neglect some of the first 2 components. In PHM, we would go along with a much broader understanding of universal coverage. So finally, before I get on to some solutions, within health systems, one of the building blocks, so-called, focuses on the health workforce or health personnel. And health personnel, in my view, are by far the most important component. They consume about anything between 60 and 80% of expenditure, and clearly without functioning personnel, we can't have operational health systems. There's a lot of evidence that the greater the density, i.e. the number of workers per population, the better the health outcomes. Yet we know that in Africa in particular, and also in Asia, the share of health workers compared to the burden of disease is really quite horrifyingly low. Africa has about 3% of the world's health workers and 25% of the world's burden of disease. And this is aggravated by migration of personnel, the so-called brain drain. And if we total up the savings that rich countries have made through what some African health ministers call brain robbery, that is, taking professionals or luring professionals abroad, the savings on all professionals, not just health professionals, imported to the OECD countries are well over 500 billion at a conservative estimate. That is the savings in training costs. So, what can we do? And I'm going to spend the last about 12 minutes or so, no more than 15 minutes, talking about key strategies and actions to revitalize comprehensive primary health care and to strengthen health systems. So, you will have heard in previous IPOL sessions, and you will hear in subsequent ones, that really equity and equitable development are absolutely key, and they seem to be a common characteristic of countries which perform very well in health. So an example would be Costa Rica, which is quite a poor country, but where equity is relatively good. It's getting worse than it used to be, but it's relatively good, compared with the US, which is an extremely wealthy country, but highly unequal, and where life expectancy in both of those countries is exactly the same. And infant mortality is a bit lower in Costa Rica than it is in the US. Countries which invest in their social sectors, including health. Countries where strong community participation and holding decision makers accountable seem also to do well. So in successful health policies, there are two kind of key components: a bottom-up and a top-down part. So the bottom-up is participatory program development, which involves also other sectors, and I'll give some examples, and a policy development process which is inclusive and transparent and involves other sectors. So in the good health at low-cost countries, countries like Costa Rica, Kerala State in India, Sri Lanka, and there are now quite a few others, these are some of the characteristics. So, as I said, promoting healthy policies and plans, if you like, top-down, and bottom-up development of comprehensive, decentralized, intersectoral health systems. But all of this only happens where the environment is facilitatory. And that, of course, begs a lot of political questions. Because in many countries, there is no community mobilization. Interestingly, in my experience in Zimbabwe, and I know Maria Zuniga's in Nicaragua, the great health improvements occurred when communities, ordinary people, were really organized, pursuing their political objectives. And this allowed for, in fact, it drove the rapid implementation of good health policies. So what's sometimes called governance is, it seems, related with improvements in health outcomes. So you can see on the y-axis here, child mortality is plotted against a governance score. And the governance score is made up of voice, accountability, political stability, effectiveness, rule of law, and so on. And you can see that there's a very marked relationship. The better the governance score, the lower are child and maternal mortality rates. So, in countries where comprehensive primary health care has been implemented, dramatic improvements have occurred, especially initially in maternal and child health care. And I've listed some of those countries. below. It doesn't include all of them. And you can see that they are of different political colors, although most tend to have fairly progressive governments. We can talk about that later. So, I'm going to end with 3 priority actions that are needed. The first one is a strong focus on access and coverage, especially at lower levels of the sector, at community and primary levels, and enhancing community participation. So, to take the example of child deaths, many child deaths could be prevented with the interventions, the technologies we have at our disposal at the moment. Many deaths occur outside health facilities, and coverage of these effective interventions is poor, especially for poor people, as I showed earlier. So now you will know this term task shifting, where tasks, actions, are delegated to less specialized health workers. So community health workers, we now know, can do a lot of things. They can treat malaria, they can treat pneumonia. Indeed, there are now 29 countries in Africa where community health workers diagnose pneumonia in children and treat with antibiotics. So let's look at a few slides of Rwanda before I pass on to the next action. So Rwanda is an interesting country. As you know, there was a genocide in the mid-1990s. Yet the country has recovered very fast, it seems, especially in the health and social sectors. So you can see there's been a very focused and big investment in health, with the total number of health personnel in the public sector doubling in just 3 years. And most of these are nurses and community-based workers, very few doctors. Just look at the trends between 2005 and 2010 in antenatal care and delivery of births. It's gone up very dramatically. Trends in vaccination coverage, up to 90% in 2010 and higher now. Trends in possession of a mosquito net, very high. And trends in early childhood mortality, well, Rwanda will probably meet its Millennium Development Goals in infant and under 5 mortality. And similarly, with maternal mortality, which has dropped very sharply. So this is in a system which is focused very, very much on care at the lowest level of the system. We can talk about Rwanda later. But there are many factors which influence the success of community health worker programs. Health system factors, most notably the ones that involve support and supervision from levels above, and community factors, which render community health workers responsive to their communities. And there are other factors as well. David Werner talked in the early 80s of the role of a community health worker, not only as a healthcare provider, but as an agent of social change. And the new task shifting terminology leaves this out. This, in a way, I feel, takes the politics out of health again. And I think it reflects a change in paradigm for primary health care. So we now have evidence that community health workers work in advocacy can actually have a big impact in health. In Nepal, recently, a community trial showed that simply organizing women's groups involving pregnant women, that was the only intervention, resulted in a 30% reduction in newborn mortality. So there's now work also in Malawi which shows something similar, showing that self-organization, facilitated in this case, actually makes an impact in health. Secondly, Another priority action is obviously to address social determinants of health or of ill health through healthy public policies and intersectoral action. So, for example, we know that obesity is a growing problem in not just northern countries, but in low and middle income countries. And in South Africa, we have a huge epidemic which is contributing to accelerating non-communicable disease problems, diabetes, high blood pressure, heart disease, and so on. So what do we need to do to address this? Well, we can't only give education about better diets. We have to somehow regulate a very unhealthy food environment with government policies, especially directed to kids. We need to ensure that people can take exercise more easily. We need to advocate for subsidies on healthy foods and taxes on unhealthy foods, like there are taxes on tobacco. And you will hear in other sessions of the IPOL, the trade environment needs to be much, much better regulated, and people need to be much more educated to take action on these issues. As the Commission on Social Determinants said, the health sector needs to become much more of an advocate towards other sectors, like ministries of trade, for example. And finally, we talk a lot about intersectoral collaboration. And most examples of success in intersectoral collaboration involve communities pushing for it. If there is not a mobilized community, it's really very difficult often to get sectors to work together. So, if we look at the issue of underweight and overweight, we see that the problem with underweight is really it has become a medical problem. And we are now seeing the promotion in many, many African and Asian countries of ready-to-use foods. Some of you will know this by plumpy nut. So plumpy nut is extremely effective. It's essentially peanut butter with added micronutrients, usually dispatched from France, where it's manufactured. It's very expensive. It certainly has a significant impact in treatment of severe acute malnutrition, and it saves time and energy of mothers. It's being heavily promoted by UNICEF and Médecins Sans Frontières in particular. And now they've introduced a new food supplement called Plumpy Dose, where mothers are advised to give children 3 teaspoons of Plumpy Dose 3 times a day to prevent malnutrition. So this seems bizarre to me, to fly out prepackaged, ready-to-use food from France to prevent malnutrition in countries which are substantially agricultural. So there's already some evidence that the use of these sorts of foods is having a negative impact on breastfeeding, possibly on local agriculture, and of course diverting resources. But most importantly, through diverting attention and activity away from the economic and political causes of undernutrition. And it would be much better to have community-based nutrition programs, intersectoral action, regulate the food environment and trade, and promote community agriculture. I won't go into this, but Brazil, which has had an intersectoral approach, has got very impressive statistics on reduction in undernutrition as depicted here. So, my last slide, you'll be pleased to know, we need, as health activists, to always ask questions. for example, about health sector reform. We need to do research to show some of the disbenefits, for example, of user charges. We need to develop well-managed, comprehensive programs which always attend to the promotive and preventive aspects as well. We need to rapidly retrain or train community health workers, equip them with community development skills and support them. We need to involve other sectors and communities. We need to challenge the unfair global regime within which neoliberal health reform is promoted. And in order to do this, we have to strengthen progressive civil society. If we don't do that, I feel we will be lost. Thank you.
Thank you so much, David. That's a masterful account of the primary healthcare. Before going into further discussion, I need to apologise that we're having a little bit of trouble on our main Skype channel, and so if viewers want to ask David questions or make comments, I request that you send them on the Skype to me directly via a bilateral Skype, rather than try and use the usual Skype channel. I do apologise for this. David, as we're waiting for some comments or questions, can I ask you to comment on the current discussion about universal health cover as a strategy for developing health systems? What's your view about that?
Well, I did refer to this briefly, and it's usually called universal health coverage. I think when you say universal health cover, I think you are probably emphasizing the financing aspect, but I think you'd agree with me that in people's health movement, we see it much more broadly. Of course, we see the importance of covering everyone with free basic health care, which will not imperil them financially. But we also see the importance of coverage with essential healthcare interventions and programs that are comprehensive in the sense that they also address social determinants. Now, this kind of broad conception of universal coverage, that kind of coverage to everyone, is not held by all players. My view, and you might concur, is that, for example, the World Bank is focused in particular on different ways of financing universal health care. And often they propose a segmented approach, namely a basic package which should be provided through the public sector, and then a more expensive, broader package which people can access through the rich people, can access through the private sector. So we are very worried in this debate about universal health coverage about which particular perspective on this will prevail. I don't know if that answers your question.
Well, in the context of a debate about what might follow the Millennium Development Goals, the WHO, which clearly has a position, or the Secretariat clearly has a position which is closer to that of PHM than it is to the World Bank, is nonetheless subordinated its position to under a broad banner of universal health coverage, which in the view of the bank obviously is about stratified healthcare with relatively unequal provision for people of different income groups. The question might be asked, what do we think about the strategic choice of WHO to obscure the nature of this debate in order to try and build some kind of general movement towards universal health coverage?
Well, I think that the position of WHO on this issue is not very different from its position on a number of issues. For example, the global health initiatives, which I talked about earlier, really were, or their presence was greatly accelerated by Gro Harlem Brundtland, who was the last Director General but one in WHO, who essentially welcomed in the private sector. And this, of course, has spawned many global health initiatives in which the private sector is involved, and often, of course, the private sector is involved for its own gain. I mean, she believed, well, this could be a win-win situation. But there are, of course, a lot of dangers. And similarly, I think WHO now, because of its weakness and because many of the member states either don't understand or are too frightened to challenge the US and other big countries, really attempts to form an alliance with and not be critical of approaches that are led by agencies like the World Bank. I think it reflects WHO's weak financial and ideological position. I'd be interested in your views on that.
We have a couple of questions have come in. Erica is inviting us to broaden the debate from the question of universal health coverage to social protection more generally. And she's commenting that WHO's position is not dissimilar to that of ILO. And how you see these two issues being brought together.
Yeah, I think Erica is right that social protection is something we in PHM should be pushing for much more explicitly. And indeed, in the slide that I showed, that I went through quite quickly, in the WHO definition of universal health coverage, they do mention social protection as part of coverage. And it's clear, especially in middle-income countries, Brazil being a good example, Mexico being another, and South Africa, where I live, another. Social protection is a very important health intervention. In South Africa, we know that the social welfare system, which has only been expanded because of civil society pressure on the government, really protects a lot of people from ill health or worse health than they might otherwise experience. So I agree with her in that regard. Of course, we should always, within PHM, be pushing for progressive reforms. That doesn't necessarily mean that we are reformist. I mean, we want complete change. In a way, we want a revolution. We want the global macroeconomic situation to change. We want a situation where people in countries don't have to be saved by safety nets, but at the same time, we should be pushing for them as an interim reform which protects poorer people.
We have a similar question or comment really from Ravi, who says, whose comments first of all to support the point that you're making about the relationship between equity and equality and financial policies, but commenting also that the global health initiatives have actually skimmed away a lot of public resource which should be going into comprehensive integrated health systems, into highly focused public-private partnerships. Rather than a question, you may have further comment on that.
Yeah, you broke up a little at the end, but yeah, I mean, I made the point much earlier that in my view, and there is some research, increasing body of research that supports this, the global health initiatives as a mechanism for funding health care, and which are very dominant, especially in Africa. I mean, there are many countries, as if it's the Rabbi I'm thinking of will know, there are many African countries where the majority of the health budget is actually coming from global health initiatives. So clearly, this sort of funding has privileged certain services over others and has fragmented the health system, and most of all, as he observes, it has reinforced what I call a selective approach, an approach which doesn't only select particular health problems, but it selects curative or treatment measures and personal preventive interventions such as antiretroviral therapy, condom distribution, over some of the more fundamental public health interventions. So I'm not saying that we shouldn't invest in treatment. Of course we should. But at the same time, we need to improve social, environmental circumstances. And none of the GHIs focus on this, and this is not surprising. There are no profits for any of the private sector participants in these global health initiatives from providing sanitation or ensuring food security, for example.
Perhaps I could ask you to comment on the yeah. I wonder if you could comment on the back to the World Bank and the private sector. PHM is generally arguing for public sector funding and public sector provision. The bank claims that greater efficiency will be achieved if service provision is delivered through private, voluntary, non-profit healthcare providers. Perhaps I wonder if you could articulate the logic of PHM's critique of that argument.
Well, I'll have a go, but I'm sure you can also add, and possibly others who listening in could add, even if they can't talk, they can write in. First of all, there is increasing evidence that the more privatized a health system, the less efficient it is. Maureen McIntosh, if people want to Google her, Maureen McIntosh has done some excellent work on this. She's shown that health outcomes are worse when health systems are more privatized. Of course, comparing health systems within the same socioeconomic bracket. So, of course, there's an argument that the private sector, including NGOs, can do it more effectively than public sectors. And that, of course, is based on the fact that many public sector health services are pretty dysfunctional. That is true. But I don't think that the answer is to invest in private sector, because it's clear that the for-profit private sector, by definition, is not going to be economically the most efficient. Witness the US health system. But even NGOs, we've seen, for example, with PEPFAR, USAID funding for HIV and to a lesser extent TB, we've seen a massive growth of NGOs which have been, in a way, spawned by PEPFAR and which have been very important in implementing especially treatment for HIV. But each one of them has its own small bureaucracy, sometimes just with very few field workers. In South Africa, there are many examples of such NGOs. So the admin and overhead costs are extremely high. And very importantly, the sustainability of these efforts is really something that we need to call into question. It's already the case with Congress in the US deciding to reduce spending in PEPFAR that many of these NGOs have closed up shop. And the problem is that often capacity has not been transferred to the public sector. So a lot of money has been spent. Some gains definitely have been achieved. But if we'd had this sort of spending in well-regulated, well-trained public sectors, would we not have achieved the same? So I've shown the example of Rwanda. There are other examples of public sectors doing well. Thailand's another example. Brazil's another example. Iran's another example. And of course, there are Scandinavian countries amongst the rich countries that do very well with overwhelmingly public sectors. So it's not that it can't be done. Of course, the political context is overwhelmingly important, and the degree to which citizens demand accountability from government and their health service is absolutely crucial in this regard.
David, I'd like to read to you a comment that Ravi from India has offered us, which I think is quite interesting. He says, and referring to your comment about the GHIs taking money away from a more comprehensive approach, he says that's a good point. For instance, in India, there are a few small states that do not have a significant private providers, and the public health system is very robust. Mizoram and Nagaland, for example. Actually, Kerala today is a bad example because the takeover of the private health sector there has destroyed the public health system. And while you're reflecting on that, I might just comment that Patricia from Brazil has commented that, slightly contrary to what you've just said, that her concern is that that health staff are not in fact being employed enough in the public sector. Increasingly they're being employed through other organisations, and I think you've covered that in your comments, but it's a point of some regret, I think. But perhaps you'd like to comment on Ravi's comments regarding Kerala and states with strong public systems.
Yeah, well, Ravi obviously knows much more about India than I do. I'm not sure if this is Ravi Narayan or Ravi Duggal.
The latter. The latter.
The latter. And I mean, I am not completely up to date on Kerala, but I have read and heard about the fact that some of Kerala's remarkable successes have been undermined in the more recent period. But I think that when as he implies, when the health service and other services were overwhelmingly public, there was a very very successful impact. In terms of Brazil, well, yes, it is true. I know that in Brazil, that notwithstanding government investment in the public sector, and particularly in the family health program, which is focused, interestingly, on building up especially the health center level, and there have been big advances in health. Notwithstanding all of this, the private sector in Brazil remains extremely powerful, and from what I understand is actually growing. So this is a very worrying issue, and obviously recent popular protest in Brazil indicates that inequities in Brazil remain very, very stark, although they have narrowed somewhat from very, very high levels over the past couple of decades compared to, say, South Africa, where they've increased. But I think it's still the case that Brazil is still a highly unequal society with a very segmented health system, but at the same time, the public sector, notably in health, but also in their social protection program has secured gains which a number of other capitalist middle-income countries could learn from.
I have quite a challenging set of questions from Via, who's writing from West Papua, talking about, first of all, I think these are comments rather than questions, but Via is commenting that there's a lot of competition between some of the international health agencies like UNICEF and the NGOs and local government, and that local government, where there's a lot of NGOs, might sometimes prefer to withdraw from involvement. Govinda has commented that in India there's a pressure for, under the heading of corporate social responsibility, for the private sector to participate in these public-private partnerships. Doesn't seem a particularly good idea to me. David, rather than comment further on these questions, I wonder if we could change the direction of the conversation to think in terms of PHM, People's Health Movement, country circles. What's your thinking about how PHM circles should be thinking about health system policy, thinking about their engagement in health system reform?
Oh, that's a very difficult question, because health system reform in different countries is very, very different. So for example, in South Africa is currently on the table a proposal for a national health insurance scheme, which will fund providers, both public and private, sort of purchaser-provider split. So PHM in South Africa has started to campaign heavily around this because there's a lot of public excitement. The public falsely believes it's going to get a national health system, like in the UK. But in other countries, no such proposals are on the table. So I think health reforms are very, very different in different countries. And the term reform is very misleading because it often sounds very progressive, but sometimes it's not progressive at all. It's about greater involvement of the private sector. So I think that in different, this is probably not a very helpful answer, but I think that in different situations, PHM circles need to understand very well what the main policy issues are, what are the issues that are exciting the public, as the NHI in South Africa, or you will know of the cholera outbreak in Ghana, which had communities very, very unhappy, and PHM needs to be flexible enough to be able to mobilize activity around those key and burning questions. So what would that activity consist of? Well, clearly the first step in activity, apart from getting as many forces together as possible, the first step would be to understand what's going on. So in PHM South Africa, we spent quite a lot of time analyzing what we understand to be the proposed national health insurance scheme. In Ghana, they analyzed where the cholera outbreak was occurring, why it was occurring, including interviews with local people, to prepare themselves to actually take action. And then, of course, taking action will involve holding public meetings, writing newspaper articles, lobbying politicians, etc. So I think it differs very significantly from country to country. Many of the actions will, I suppose, be focused on particular aspects of health reform, but sometimes not. Sometimes on issues which are not within the healthcare system, but which, for example, impact on health. Yesterday in Cape Town, we had a meeting in a very poor so-called township, a slum area, around housing. There's terrible public anger, quite rightly, about housing in Cape Town. In Cape Town, we estimate that half of the population of Cape Town, almost 1.6 million people, are living in extremely hazardous, poor housing, which is clearly affecting their health. So this is an issue that PHM South Africa is also campaigning around, but it's nothing to do with our current health sector reforms.
David, just taking up the point that you've made, that the health policy environment is very different in different countries. In Europe at the moment, there's a lot of so-called discussion of so-called austerity, and clearly that's having a big impact on health systems. I'm sure people are familiar with what's happening in Greece, with the downsizing and privatising of the health system, and in England with the continued restructure of the NHS to look more and more like a private market, and to perhaps soften it up for privatisation. What's your thinking about the way PHM in Europe should be addressing this so-called austerity pressure?
Well, yeah, I mean, we are seeing this all over the place. I mean, the sharp end is presently in Europe, particularly in Southern Europe or in the weaker European economies. So clearly this becomes kind of a common campaigning issue for PHM in Europe and beyond. But of course it takes different forms in different countries. So, in Greece, as I understand it, many services have actually been withdrawn in the past recent period. In the UK, they haven't yet been withdrawn, but they're much more difficult to access. And in certain countries, there's discrimination against immigrants and refugees. As a way of making sure you don't have to pay for these people. So I think that the campaigns will take different forms in different countries. I think it's terribly difficult in some countries, the UK I'm thinking of here, because the reforms are so opaque, they're so difficult to understand, they're dressed up in such progressive rhetoric, whereas in a country like Greece, it's clear what's happening, absolutely clear what's happening. Large numbers of public sector workers are being dismissed, services are being withdrawn, prices are going up, salaries are going down. It's clear. Whereas in a country like Britain, it's much more stealthy and in some ways more difficult to campaign around.
I think that the PHM position would also be that it would be very hard to campaign on health policy issues without addressing the macroeconomic issues which are driving the austerity, in particular the sort of salvaging of the banks and the restructuring of the of public finances in order to support the private financial sector. It's not always clear how to bring those two together.
Yeah, I mean, in PHM we do kind of pride ourselves on having a holistic analysis, being able to analyze very specific health problems by taking them even to the global level. However, in campaigning, I think it's very, very important to relate to public concerns, and that in the early stages the public may be completely bewildered if one proceeds directly to kind of the global financial crisis, if you see what I mean. So I think that the way in which this kind of comprehensive analysis is communicated and related to particular struggles is also very challenging, can be very, very challenging. For example, in South Africa at the moment, I've been doing some work with colleagues around this escalating problem of obesity, overweight, and attendant non-communicable diseases, which truly is a crisis here. It's truly a crisis. It's already showing itself in the health sector with diabetics who are type 2 diabetics who are only in adolescence. So we've done some research to show how the food environment has changed absolutely dramatically in the past 15 years, with the increasing intrusion of foreign transnational food corporations, the increasing domination of the food supply by packaged processed foods emanating from fewer and fewer countries, and so on and so forth. And South Africa is a place that McDonald's sees as one of its best markets, as do Coca-Cola. But it's quite difficult to start campaigning immediately around food trade, for example. We have to start with where people are at, and people are only starting to recognize the existence of this particular health problem. So we try to link all of these different aspects and make it very clear that unless we address the broader political economy of food in this case, we're not going to get very far with reducing the increasing incidence of food-related NCDs.
David, this has been a wonderful survey, and thank you so much for your time. Do you have any, we need to draw to a close, I'm afraid. Do you have any sort of final comments you'd like to leave us with?
Well, not really, except to say I wish I knew who was online at the moment, whom I was speaking with. I suppose my final comment is very obvious, that the current crisis, which is a capitalist crisis, is clearly having a major adverse impact in all corners of the world. And there is, as yet, very little organized resistance to this. We can see pockets of resistance. We see many mass mobilizations, particularly in Southern Europe and North Africa. But there isn't, it seems to me, in many places, a coherent leadership which can help to take forward those struggles, participating in them, towards a conclusion which goes beyond the kinds of solutions that are currently offered. It's very depressing to see what happens in Egypt. You have mass mobilizations, they overthrow a dictator, a new government comes in, it fails to deliver, unsurprisingly, given that it doesn't tackle any of the fundamental economic issues. That government's overthrown, and what will it be replaced with? No doubt, a Western-friendly government, which will, again, not address the problems. So we need to create a broad-based mass movement, and I see PHM as being, if you like, one stream, hopefully flowing into an enlarging river of protest. We are the health stream. We want the climate stream, the youth stream, the women's stream, the stream on other areas of struggle also to grow. Because if we don't create this big river, I'm afraid the future is very bleak for all of us, especially for younger people.
David, thanks so much. That's a really deep challenge for all of us, and in particular for our IPOL colleagues who are working through some of these issues at this current time. I think at this stage I'll say thank you very much, and good morning, good evening, good afternoon to the guests who've been online with us, but the video will remain online and people will be able to watch it at their leisure. Thanks very much indeed.
Thank you. Bye-bye.
Cheers.